Going to take a couple seconds for some more people to show up, and then I'm going to have a couple questions for you guys to get us started. Some of you are letting me know where you're coming from. We've got somebody from Qatar, from Kenya. Welcome. From the Philippines. It's 3 a.m. Rose, thank you for joining us at 3 a.m. You're more committed to your studying than I ever was as a student. I would be sleeping. Excellent. Okay. Christina, you are determined to pass next time. I think so, and we're going to help you out with that today. So, all right. Princess is confident with us. Good. I'm glad. We love to help students, make students confident. All right, some more people are showing up, but I'm just going to ask a quick question. If you guys were going to take the NCLEX tomorrow, theoretically, on a scale of 0 to 10, how prepared do you feel, or how confident would you feel that you would pass on a scale of 0 to 10? I'm going to let y'all answer, but we got some more people coming in from Malawi, Tanzania, Canada. That feels like as foreign to me as Nigeria or Malawi does, I'll be honest. I'm in Texas here. So excellent. Waiting for some numbers for how prepared you guys are. Okay, 6, 7, 8, 5. Good. All right, so we got a range of scores, mostly 5 to 8, some people a little bit lower. So Tiana said that she's 5 with a crying face. And so I want to say something about that. A lot of people go in and they take the NCLEX and then they leave and they say, I'm sure I failed. It was so hard. I'm sure I failed. And because NCLEX is an adaptive test, that means however prepared you are, whether I'm taking it and I should theoretically be pretty prepared, or you're taking it or one of your professors, the computerized adaptive testing gives you a question that it believes you have a 50% chance of answering correctly. So that means that you are going to feel like it's a really hard test and you're going to feel like you were guessing when you're passing, right? So hopefully that'll give you a little bit of reassurance that when you're actually sitting there taking the test, if it feels really challenging, that's a good sign because that means you are getting passing level questions. So don't let it trip you up, just keep going. So awesome. All right, so we've got some people coming in. We'll go ahead and get started. So thanks again for joining us today. My name is Dr. Emily. I'm one of the co-creators here at NCLEX Bootcamp, and I've got a moderator from our team helping out in the chat. So between the two of us, we will try to answer all your questions and address any concerns today. If there's a little bit of a delay, I'm not ignoring you. It just takes a minute for me to see your comments come through on my end. But yeah, so thanks for joining us. We're going to be talking about how to study for the next generation NCLEX, and I love helping students pass the NCLEX. I've been in NCLEX prep for about 10 years now, and I hope that these tips that I've learned along the way are going to be helpful to you guys. So, okay, to get started, we are going to look at what the purpose of the NCLEX is, because that's going to help you understand this second point, or what's on the NCLEX. We're going to look at those top 5 client need areas that are covered on the NCLEX. And then we're going to spend most of our time talking about how to study. And just to give you a little hint, the secret is no secret. It's just to practice, 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 practice. And so we are going to spend some time practicing the biggest section on the NCLEX. So what then is the purpose of the NCLEX? And I want to ask, how many of you guys have heard that the NCLEX is a safety exam? And I think probably most of you who have heard that before, right? That the NCLEX is a safety exam, and that's because it's true. So the goal of the NCLEX is to protect the public. So it might be for you to get your RN, to start making money, paying off those student loans, but at the end of the day, the NCSBN wants to protect the public. And so the NCLEX is designed to make sure that by passing it, they can say you are a safe entry-level nurse. And they define entry-level as a generalist nurse within that first 12 months of practice. And this is general practice, so not somebody who's super specialized in like the NICU or the cardiothoracic ICU. This is something that if I, who only have adult ICU experience, was floated to the NICU, I would know the basics, right? How to recognize acute changes in clinical status, how to protect their skin, keep them clean, things like that. So we're looking at generalist practice, and that's what we're all about at NCLEX, is helping you focus on what's actually on the test. We're not going to go way into the weeds with stuff that's just nice to know, but you're never actually going to see on the exam. So then what topics are on the test? And you guys might not know that there's actually an NCLEX test plan. So there is an official test plan that has a whole list of topics that disclose what is on the test. And so this is based on a survey of actual practicing nurses. And every 3 years, they conduct a survey, and practicing nurses are asked within your last shift, how often did you do each of these tasks, and how important are each of these tasks, and then how much clinical judgment is required for these. So you can imagine things like hand hygiene, checking 2 patient identifiers, going through your 10 rights of medication administration. Those are going to show up a ton on the test because they are really important. They require a lot of clinical judgment, at least your 10 medication rights does. And they are something that we do all the time. So you're going to see a lot of safety infection control, management of care, where we're prioritizing between tasks because we always have more to do than there is time to do it. And then, of course, you're going to see a lot of emphasis on things like pharm, because could be really harmful to our patients if we don't know how to safely give medications and monitor for their effects. And so we're just centered on what is going to make you a safe practicing nurse. And so the top 5 client need areas actually make up over 70% of the exam. So that's where we want to focus our time, right? It's going to give us the biggest bang for our buck. And so in a 100-item NCLEX, which this is about the average length of an NCLEX, the number 1 is going to be clinical judgment. So 25% of your test score performance is going to come from your ability to demonstrate that you can use clinical judgment or critical thinking in the scenarios in the question or the case that's being presented to you. And so the NCLEX tests clinical judgment in the form of those case studies that we all know and love. And I'm going to ask you guys to let me know in the chat if you had the opportunity to actually practice with case studies during school, or if you're kind of new to next-gen cases. And so if you haven't played with the NCLEX Bootcamp next-gen cases, students say they look more like the real test than anybody else's. So I really encourage you to check them out. But yes, clinical judgment, that's about a quarter of your test. And then management of care comes next with things like prioritization, delegation, assignment, pharm and parenteral therapies, like we talked about. This can be really harmful if we do it wrong. So we want to make sure we're keeping our patients safe with the medications we're giving them. And then physiologic adaptation, that's your general nursing process with most common disease processes and problems. And then, of course, safety and infection control. And so today we're going to spend time looking at clinical judgment practice, because this is what you really need to nail to pass your NCLEX. But if you know that you struggle with some of these other areas too, do not worry. We've got plenty of practice for you. And in fact, we even have our new NCLEX cheat sheets that are available for free. And if you guys stick around till the end, our moderator is going to leave a comment for you to help show you where you can go to download a couple cheat sheets for free, including some of our popular ones, which are our prioritization cheat sheet and our delegation and assignment cheat sheet. Because the new NCLEX is not as simple as ABCs, right? So we're going to help you with everything you need to know to pass. So when they do test clinical judgment, they use this 6-step clinical judgment measurement model. And this is basically just the 6 questions in a case study. And so you might not be familiar with this, but you've probably seen the nursing process before, ADPI, and this is really similar. So we assess or figure out which of these cues is most important. We diagnose or analyze what could it mean. We figure out where do I start and what solutions or actions can I take to address that priority problem. We actually take that action, do the thing, and then evaluate, did it help? And so then how to study? And like I said before, the answer is just practice. And so why and how do we practice for the NCLEX? And this is because practice makes perfect, right? This allows you to actually apply your knowledge from school in the same way you're going to be using it on the test. Right? So if you were a basketball player and you were trying to practice your free throws, you wouldn't go spend hours practicing dribbling up and down the court, right? You would need to practice free throws. You need to practice in the same exact way that you're going to be using the skill. And in this case, the skill is answering questions on the NCLEX. So you want your questions to look just like the NCLEX. So we've made sure of that for you here. and feel just like the NCLEX and ask about the same content. And so that familiarity is going to build your confidence, it's going to reduce your anxiety, so that by the time you actually sit down to take the test, it's going to feel like just another bootcamp practice test, right? And it's going to expose you to the high yield topics that are going to come up over and over and over. And you guys have gone through our case studies, probably saw there all the time we're using words like perfusion. We're pointing out which assessment findings or interventions are going to be related to problems of perfusion or oxygenation or airway. And so you're going to get familiar with these high yield topics and prepared for the test. And remember that every question is a learning opportunity. So whether you get it right or wrong, that rationale is there for you to understand the why. Why did I get it right or wrong? Why would this answer have been incorrect? So we encourage you to take the time to read the rationale for every item that you answer, and then you can even use our tagging system to keep track of the ones that you know you need to review a little bit more. And then it's always a good idea to be structured. So based on when your testing date is, you can follow a study schedule. And we do have 1, 2, and 3 month study schedules for you that give you day by day what questions to practice, what cheat sheets to review, when to take a readiness assessment, and how to incorporate all those pieces into your study. And our moderator is going to leave that in the comments for you so that you guys can go check out our study schedules as well. And then you want to track your performance over time. It's okay if you're, performing a little bit lower than everybody else, as long as you're able to see that you're consistently improving as you go. And that's the normal progression through our question bank. And then, of course, you want to prioritize high yield content, so not spending too much time on stuff that's really overly specific and is only going to help you answer a couple questions. You want to spend your time reviewing stuff that you're going to be tested on a lot. And remember that number one client need area is clinical judgment. So we are going to be focusing on clinical judgment today. And on the NCLEX, that is going to be in the form of the case studies. But just to save everybody some time today and prevent us from having to read through lengthy case studies, we're going to look at 6 items that test those 6 clinical judgment steps the same way that you would see them in a case study. All right, so first, recognizing cues or figuring out what's most important here. And so we've got this sample question to look at. The nurse is caring for a client with severe COPD. Which of the following findings would require immediate follow-up? And when the NCLEX asks you this, what they mean is, which one of these is an unexpected abnormal finding? Because somebody with COPD, even when they're completely stable, they're not going to have a perfectly normal assessment, right? You're going to have several abnormal findings, and you have to exercise your clinical judgment to figure out what can I just document and what do I need to act on. And so let's consider each of these. Lower extremity edema, paradoxical respirations, an increased hemoglobin level, or a pulse ox reading of 88%. And I see a couple of you dropping in 2, as well as some other answers. All right, so let's talk about this. Quick review of COPD. So COPD is either going to be chronic bronchitis or emphysema, and both of these will result in kind of air trapping and limited airflow. So with chronic bronchitis, smoking is going to cause chronic inflammation and mucus production and narrow the airway, so we can't get air in. And with emphysema, it damages the alveoli so that when you breathe out, this collapses in on itself and you can't get air out. And most patients with COPD have an overlap of both of these. So this is our issue with COPDs. We can't get air in and out. A couple of you said 2, 4. All right, so let's talk. For lower extremity edema, why would a patient with COPD develop lower extremity edema? Okay, a couple of you said 1, 2. So do you guys remember what cardiovascular complication might happen from COPD? And there are several that might just be related to smoking, but the big one, right, is if you have too much pressure and stress in your lungs, then that's going to strain your heart and can cause heart failure, right? And so you could see some signs of heart failure. But this is describing lower extremity edema, which is basically you've got swelling in your lower extremities. What would I do about this if I was immediately going to follow up on it? I would just elevate their legs, maybe, right? It's not saying that they have pulmonary edema, that they have crackles in the lungs. It's just saying lower extremity edema. And Keep It a Secret 15 says right-sided heart failure, and you're right. So yes, that would be the right side of the heart that's strained because that's what side pumps to the lungs. So this is not a normal finding, but I don't know that I need to immediately do anything about it. The next, paradoxical respirations. Several of you guys guessed this, and paradoxical respirations is when you normally, if you don't have paradoxical respirations, you breathe in and your chest rises, and you breathe out and your chest falls. When you see somebody with paradoxical respirations, that means you're seeing the opposite happening. They breathe in and their chest wall kind of sucks in, and then they breathe out and it pushes out. And so that is because they're working really, really hard to breathe. And that is a sign of impending respiratory failure. And so if you guys see paradoxical respirations in any patient, whether they have COPD, whether they have asthma, this is always a warning sign for respiratory failure, and I do not want to ignore it. So I'm thinking that's going to be my answer, but let's check the others just in case. Then an increased hemoglobin level. So do you guys remember why somebody with COPD might have an increased hemoglobin level? And it has something to do with the fact that they've got low blood oxygen. Gina said COPD patients typically have a lower oxygen saturation, and that's true. These patients are so chronically hypoxic that in an attempt to kind of get more oxygen delivered to the tissues, it thinks, oh, I just need more hemoglobin. If I just make more hemoglobin, then I can carry more oxygen to the tissues. And that's why they will have something called polycythemia vera, or they will actually have an increased hemoglobin level, and it's a compensatory mechanism. So on the NCLEX, do not be tricked. They are not going to have anemia, right? They're going to have polycythemia. So this is an expected abnormal finding, but it's also chronic, and it's not something I'm going to do anything about. So we can omit that one. And then a pulse oximetry reading 88. Gina is correct. They typically have a lower oxygen saturation, like 88%. We don't want to go overboard with oxygen on these patients. Instead, we want to titrate for a pulse oximetry to keep it above 88 to 92%. So this is a safe range. It's not something I would do anything about. So you guys are right. Most of you guessed paradoxical respirations, and that is the thing that I would immediately intervene for. And as you can see, only about 57% of our users in the bank, and I think several thousand of them answered this question. So only about 60% of them got it right. And so you guys who got it right are ahead of the curve. And well done. If you didn't, now you know, and you can just review our COPD cheat sheet. Then next, we're going to analyze cues or figure out what could these cues mean for my patient. And so here in this patient, we've got a suspected chronic venous insufficiency. Which of these findings is going to support that diagnosis? And the NCLEX loves to ask about venous versus arterial problems, right? And so we're going to see some findings here that are arterial, some that are venous problems. And when you've got peripheral artery disease, this is when you've got narrowing, usually from smoking, sedentary lifestyle, atherosclerosis, and we can't get blood to the lower extremities. So when you see problems on the leg, they're going to be on the distal most part of the leg because that's where the blood flow is lowest. So when you've got ulcers, they're going to be down here on the toes, the shins, and then you're going to have kind of those 6 Ps of neurovascular insufficiency, the pallor, pain, pulselessness, and so on. Whereas with chronic venous insufficiency, you are going to see these valves are insufficient and they kind of collapse, and so, or they fail to collapse, and so blood is going to pool in the legs. And so that way we're going to see kind of higher up on the leg, you're going to have these issues with the ulcers, and you're going to have a lot of swelling and fluid retention and see signs of fluid retention. So knowing that, absent pedal pulse, is that more arterial insufficiency or venous insufficiency? And I'm going to ask you guys the same thing for each of these, but remember, pulselessness, that is a sign of, okay, Barad says compartment syndrome. Yes, that could be a sign of compartment syndrome, the absent pedal pulse. It's a sign that we're not getting enough blood flow to the lower extremity, whether that's because of compartment syndrome or something else. But in this case, it's not a sign of venous insufficiency, it's a sign of arterial insufficiency. Then the intermittent leg cramping. Well, this also happens with arterial insufficiency because when you're out walking, using up all of that oxygen in the muscle, it can't get enough blood flow back to the muscle in time, and so it starts to cramp and get ischemic. So that is also an arterial finding. Then ulcers on the toes. Remember, when you have ulcers with arterial insufficiency, it's going to be at the most distal part of the foot where we can't get enough blood flow. So that's also an arterial problem. Then a brown discoloration. So we didn't talk about this, but you guys know that all the previous three were related to arterial insufficiency. So I think it's got to be this one, right? And let's talk about this. So why would I see brown discoloration in somebody with chronic venous insufficiency? And so this is an interesting complication where basically because that blood is pooling in the lower extremities, normally as those blood cells return to the body and die, they would be recycled in our spleen, but instead they die in lice. And what's inside of a red blood cell but iron, right? And so all that iron just gets deposited into the skin, hemosiderin deposits, and it creates this brown discoloration. And I like to think of this as being like it's rusting, right? Like iron sits out, like the blood is pooling and it just rusts. So this is a sign of venous insufficiency. And most of you guessed this correct, so well done. And again, only about half of our users got this right, so you guys are doing excellent today. Then okay, prioritizing hypotheses or figuring out where do I start. And I'm gonna ask you a question. So let's say you are in the neuro ICU and you are getting a patient from the OR who just had a craniotomy. What is the number one complication that you're worried about and that you're thinking about? What would you prioritize? Let's assume, they're coming on the ventilator, so they have their airways intact. We're worried about a complication from craniotomy or any kind of head surgery, head trauma, and that's going to be an increase in ICP. And Joseph got it. Joseph R. got it. Increased ICP. Yes. And so in this next question, we are going to figure out what assessment do I want to prioritize in this plan of care for this client who's at risk for increased ICP. Good. Mai and Sulema, you guys got this as well. Well done. So these are all of these options here are part of a normal neuro assessment. I'm going to assess all of these things. But as far as what I prioritize is a different story. So the Babinski reflex, that's where you stroke the foot, right, and watch which direction the toes go. That is an important assessment, but it's also more related to a spinal cord problem, not a problem of increased ICP. So this is useful, but I'm not going to prioritize it. Then the presence of a headache. Well, would you have a headache with increased ICP? Yeah, I think you would, right? But wouldn't you also have a headache because you just had brain surgery? Yes. So if they have a headache, that doesn't really tell you necessarily that they have increased ICP. It just might tell you that they have had brain surgery, right? So this might not be as useful. We'll hang on to it. Then pupil size and reactivity. You guys have probably heard that the pupils are the windows into the brain, and that is true. You will see pupil changes when you have swelling in the brain and it compresses that optic nerve, but this is a late sign. It takes a really long time for pupil changes to develop, and by the time you're going to see a blown or fixed pupil, it might be too late to take them back to the OR and insert a drain. But this final one here is what most of you guessed, and you are correct. The LOC is going to be your earliest and most sensitive indicator of changes in ICP. So that's the first thing you're going to notice when your patient's ICP starts to go up. They're going to be less responsive, lethargic, drowsy. You might have to, give them a little sternal rub to wake them up. And so this is what you want to prioritize: going into the room, saying their name, making sure they can wake up and talk to you normally. So we are prioritizing that level of consciousness assessment. And well done. So this is a need to know, and I think most of you, almost everybody got this one right. But that is a need to know for the NCLEX. So don't miss this one. Level of consciousness is what you want to assess for changes in ICP. Then next, generating solutions, or figure out what can I do about this problem. So here we have a patient who just underwent coronary angiography via the femoral artery. So what condition is this done to treat? And I think you guys should all know this one, but who would come into the hospital and get an emergent coronary angiography? And while I'm waiting for y'all to answer, we'll read on. So we're asked, which interventions do we anticipate in the initial post-procedure care for this client? And this is a select all that apply. And here's an NCLEX tip for select all that apply questions. You want to treat each option as if it's its own true or false. All right, Christina got it. Christina says ACS, that's correct. So if you've got acute coronary syndrome, we need to thread this catheter up. The cardiologist will do this to the site of the blockage and place a stent to open it up and restore blood flow to the heart. Francis says heart attack in all caps. Yes. Very good. Oops, just kidding. Don't look at the answers, guys. So do we want to place them on a fluid restriction? True or false? And so I hope, and it looks like some of you have selected this one. Now remember, when we go up and visualize this, they're going to need to get contrast dye. And there's one organ in the body that hates contrast dye. And I bet Christina knows. She says no to this one. But yeah, it's the kidneys, right? If you give too much contrast and not enough fluids to flush it out, you can develop contrast nephropathy or kidney failure. And so yes, Faustina, false. You're correct. This one is false. We do not want to place them on a fluid restriction. We want to push fluids either orally or through IV or both. Good. Then monitoring the puncture site for swelling. Yes, because not only did we just puncture the femoral artery, which is one of the largest arteries in the body, but they also get aspirin and heparin and a bunch of anticoagulants for this procedure. So they are at high risk for bleeding. So we're going to go in there, look at the groin site and assess it for swelling, right? And so that is something we want to do because we're worried that they might bleed out into their leg or into their abdomen where we can't see it. Then placing them on continuous cardiac monitoring. Yes, I'm going to assume you guys know this because we talked about the fact that it's for a cardiac issue, either coronary ischemia or an acute coronary syndrome. And so there's always the risk that that stent can close or collapse and we would lose blood flow to that part of the heart that we just restored it to. So that is correct. Then assisting them up to the chair to prevent atelectasis. This is number 4, and it looks like about half of you or maybe a quarter of you are guessing this one. And so we do, in general, want to mobilize our patients after some kind of procedure. But in this case, remember, our priority is we're worried about bleeding at this site. And so if they bend at the waist, that's going to put a lot of pressure on this site and can risk life-threatening hemorrhage. So they need to stay totally flat for, depends on your hospital, but on the NCLEX, it's going to be 4 to 6 hours. So that is a long time to stay totally flat. And they're going to need some reassurance for how important it is. They need to keep that leg straight. So no, we're going to wait until they are off of bed rest to implement any kind of ambulation or getting up to the chair. So it's not this one. Then palpating their bilateral pedal pulses every 15 minutes. Yes, so remember, we're worried about bleeding. If we're seeing bleeding from this femoral site, that means the blood is going to go somewhere other than their pedal pulse. So when we palpate, we're going to have a strong pulse on the unaffected side and a weak pulse or absent pulse on the operative side. So this is definitely important. All right, so we're going to give IV fluids, not restrict fluids, keep them totally flat, place them on cardiac monitoring, and we're going to watch for bleeding by checking their pulses and looking at that groin site for bleeding. Very good. Well done. All right. Then we're going to take action or actually implement the action that we know the patient needs. So here we've got diagnostic results for a patient who became unresponsive and has no palpable pulse. They've got gasping respirations. So we look at our diagnostic results here and we've got this EKG tracing. So what is y'all's interpretation of this rhythm? I'm going to let y'all kind of trickle in your answers for that. But we're being asked, which of the following actions should the nurse take? Should we initiate chest compressions, give IV push atropine, obtain a 12-lead electrocardiogram, or deliver rescue breaths? Several of you are answering 1. Shimaja says NCLEX can be really tricky. That's because nursing practice can be really tricky, and I know it. And so we want to give you lots of practice with these kind of tricky scenarios. All right, Marky says PEA. All right, start CPR. So most of you want to start CPR, and I am glad. I would definitely want you as my nurse if you would start chest compressions for this, because there's really only one piece of information in this question that you need to answer it, and it's actually right here. No palpable pulse. So it does not matter what your monitor shows. If your patient doesn't have a pulse, that means this is a pulseless rhythm, whether it's PEA, pulseless electrical activity, or VFib or VTAC. You can have all the electricity you want, but if it's not actually generating a cardiac contraction and a pulse, this patient needs CPR. And it's important to do this quickly because that's going to pump blood and restore blood flow while we're trying to give epinephrine, shock them, or do whatever else to correct the underlying cause, which in this case would be your H's and T's, right? So yes, we are going to initiate chest compressions ASAP because every second we delay it, their brain tissue is dying, right? So very good. I'm glad you guys got this one right. But why would we fall for some of the others? Because you're right, it is tricky. This is a tricky situation to be in. So giving atropine, that would be appropriate for bradycardia with a pulse, right? If this patient was kind of symptomatic, dizzy, had chest pain, and then they're talking to us and we put them on the monitor and we see this, that would mean we would need to treat this as symptomatic bradycardia, and giving atropine or pacing, actually putting them on a pacer, will correct that and get the heart rate up. But this is not that problem. This is pulseless, right? So this is incorrect. Then getting a 12-lead EKG. Again, we already have all the information we need. It doesn't matter what the EKG shows. We know that they don't have a pulse, and that's all we need to know. Assessing first is not always the right thing to do on the NCLEX. That might have worked with the old NCLEX, but you guys have been told, oh, on priority action questions, always assess first. Sometimes you have all the information you already need. And in this case, we do. So this would just delay care. Then delivering rescue breaths. If they had gasping respirations and a pulse, then we would probably give rescue breaths, right? We would maybe, in the case of an opioid overdose, just use the bag valve mask, give some Narcan, but again, this patient doesn't have a pulse, so CPR is our priority. Very good, and 55 or so % of our users got this right, so you guys are just all ahead of the curve. Okay, then evaluating outcomes or figuring out, did it help what I did for them, or in this case, what I taught them? Was my teaching effective? So this patient's undergoing a total laryngectomy, or we're actually surgically removing the voice box, right? And so which of these statements by the client would require follow-up? And so the larynx, remember, is here. It's the voice box, so it is in the throat. It is a throat surgery. And they're going to go in and actually remove the voice box. And so which of these statements would require follow-up? And what that means is which of these has the patient said incorrectly, and we need to either revise teaching or get the healthcare provider to come provide them some more education about, or what. So I will have to practice using a mirror to care for my stoma. Well, yes, that is important. We really want these patients to care for their own stoma before they leave the hospital. This can be a very emotional surgery. They might lose their voice. I mean, they will, right? And they're going to change their body image. And so it's important that they maybe use a mirror, and we kind of coach them through getting comfortable practicing caring for the stoma, just like you guys are getting comfortable answering tricky NCLEX questions. So this is correct. It does not require follow-up. Then when I'm discharged from the hospital, I won't need the feeding tube. Yeah, we're not going to be, taking out their tongue. They shouldn't have any issue with swallowing. This is just their voice box. We're omitting totally different pathway. The air travels in and out of your lungs to generate your voice, not your stomach, your esophagus. So they should be able to chew and swallow just fine. My husband's bought me some scarves to wear over the stoma. And this is also fine, right? As long as it's not like dirty or too tight, then there's no issue with that. And that can be really helpful in helping them adjust to their new body image. Same thing after like a thyroidectomy. And then I see that Marky says larynx is a voice box. It will not return to normal. And yes, that is correct. If the patient says, after this surgery, my voice is hoarse but returned to normal, we want to make sure they understand before they go into this surgery that no, we will be taking their voice box out. They will not have a normal voice. And what this is showing here is a voice prosthesis, where basically you can redirect the airflow temporarily and create this kind of digitized sounding voice from the airflow. And so this is part of informed consent, right? That the patient would understand the risks and benefits of the surgery. In this case, that the outcome would be they would basically be cured, hopefully, of whatever laryngeal cancer, but they won't have a normal voice. So this would require follow-up. And you guys are right. And this was a trickier one. 41% got this right. So you guys are doing great. So excellent, everyone. You guys did so well. Great job. And I want to take a second to ask if you have any questions. So please leave your questions in the chat. We'll take a second or two and just kind of answer any questions. But in the meantime, you might go check us out on our socials here. Subscribe here to our YouTube channel if you haven't already. Please join our Facebook study group where we all encourage each other who are studying for the NCLEX or have just passed. And then I will take a second to answer your question. So yes, Gina, this procedure would be needed usually from laryngeal cancer. So if somebody was a smoker and it's very common to develop cancers in the tongue, the esophagus, the throat, the larynx, and so we can surgically remove that. Good. Christina says, how many more of these will we be doing? Christina, we're going to try and do one of these each week. They're usually going to be Tuesday, Wednesday, or Thursday. And the next one you can actually see on our upcoming live channel. You can set for a reminder. But we're going to try and do these every week to make sure you guys get lots of question practice in. And then how can you stay calm during the exam? So I would say the best thing is to be prepared, right? The more practice that you have answering these questions, the more you're going to feel confident, like you know what you're doing. You're going to have less anxiety. On the study schedules on NCLEX-bootcamp.com, we have a built-in day, usually on Saturdays or whatever day works for you, to take full-length practice tests, to actually sit down, put yourself in the mindset of the test taker, treat it like it's the real thing, and just practice sitting down and taking every question as seriously as if you're answering it on the real NCLEX. So you just got to get comfortable being uncomfortable. Anthony says, anxiety can get you the first time for sure. So we want to give you all the practice that you need. Gina, our prioritization webinar is very cool, and I encourage you guys to bring it. Marky wants to know, is there a video for test taking strategy? So we actually have a whole NGN strategy course that teaches you how to think like a nurse, how to think through these questions, and so you can come check that out on NCLEX-bootcamp.com. All right. Very good. Stella wants to join the study group. Yeah, so here at on Facebook, NCLEX Bootcamp Official, that's our study group. You can just go ahead and apply to join the group and we'll accept you if you answer the questions. So very good. I think I've got most of your questions. Anything I missed, our moderator is going to come in and answer for you, but thank you again, everyone, for joining us. We hope that those of you who answered, you had like a 3 to 5 out of 10 readiness at the beginning, that we've boosted your readiness by at least a couple of points. And to get you the rest of the way there, please come to NCLEX-bootcamp.com and check out all of our other resources for you. So thanks again, and y'all happy studying.